Our next paper was going to be Professor Inoue's video on the clinical results of the POEM procedure. As many of you heard, he remains in Japan working in his hospital, taking care of disaster relief victims, and you know, one of the great privileges of being the incoming president is that I can invite you to come to the plenary session next year where we will give this paper due consideration when Professor Inoue can come and join us. So that's your invitation to join us in San Diego next year. And it's with you know, great sadness that we share our greatest hopes and wishes for the recovery in Japan. Our next paper is laparoscopic Dor versus Toupet Fundoplication following Heller myotomy for achalasia, results of a multi-center trial that will be presented by Dr. Arthur Rawlings.
Thanks. So on behalf of the research team, I'd like to thank SAGES for this opportunity to present our laparoscopic Dor versus Toupet Fundoplication after the Heller myotomy. As was said, my name is Arthur Rawlings, and Dr. Brunt's the senior author. These are our disclosures. Laparoscopic Heller myotomy is the preferred treatment for achalasia. The results improve in dysphagia of symptoms and quality of life. There are studies that show that myotomy alone does predispose a person to acid reflux. And there are other studies that show that a partial fundoplication is preferred because of the higher incidence of dysphagia in long term with a 360-degree wrap. Some people do advocate a Dor fundoplication for several reasons. One is that it avoids the need for complete posterior dissection and does not completely disrupt the supporting periesophageal ligament. It does cover the exposed esophageal mucosa, and some people would say that it's less complicated to perform. However, other surgeons would advocate that you should do a Toupet fundoplication after a Heller myotomy because it keeps the edges of the myotomy separated and it possibly provides better anti-reflux control. No studies have prospectively compared these two types of partial fundoplications, and the selection has been basically at the surgeon's choice. The present study was designed to assess symptomatic and physiologic differences between a Dor and Toupet. So we had two study aims. One was to assess the differences in reflux symptoms and 24-hour pH testing between a Dor and Toupet fundoplication after a Heller myotomy. And we wanted to evaluate improvement in symptoms and quality of life between the two groups. To do this, we had a randomized prospective multi-centered trial that included these institutions. IRB approval was obtained at each site before we began the study. As part of our research protocol, we had preoperative testing of all patients. They underwent a barium swallow, esophageal manometry, and also upper endoscopy. Each patient had an esophageal symptom and SF06 questionnaire that they filled out. They did this preoperatively, a 2 to 6 week follow-up, 6-month follow-up, and a 12-month follow-up. As far as the esophageal symptom questionnaire, it was one that we designed. It was a 5-point Likert scale, 0 to 4 on the scale. And it looked at 7 symptoms, and we looked at the frequency and the severity of these symptoms, such as dysphagia to solids and to liquids. Then the patients underwent physiologic testing at 6 to 12 months after the procedure. The inclusion criteria for our study was symptomatic documented achalasia, and you had to be 18 years old or older to participate. Exclusion criteria included a primary or secondary esophageal motility disorder other than achalasia, some prior gastric or esophageal surgery, hiatal hernia greater than 5 centimeters, or some associated disorder that required long-term medical treatment such as Crohn's. When we looked at the data, we separated it by mean and standard deviation or median and range depending on what was collected. Our statistician analyzed the data with appropriate tests depending on what data was collected, and we used the p-value of 0.05 to be considered for significance. There are 85 patients who were enrolled in this study between 2003 and 2008. These were randomized to 49 Dor and 36 Toupet. 25 patients, however, did not have protocol follow-up and are not included in this analysis. This left us with 60 patients to analyze in the study, 36 in the Dor arm and 24 in the Toupet arm. 43 of those, or 72% of them, had pH testing between 6 and 12 months after the procedure, 24 in the Dor arm and 19 in the Toupet arm. In looking at the two arms, we wanted to make sure that they were very similar. So when we compared the Dor and the Toupet arms on age, gender, and A classification, there was no statistically significant difference. We looked at preoperative motility testing, and there was no difference between the two groups, as you can see in the p-values. We also looked at their preoperative symptom as far as frequency. You can see at the bottom of the slide, dysphagia to solids, liquids, heartburns, and so forth. And there was no difference between the two groups as far as the frequency of their symptoms. There was also no difference between the two groups in the severity of their symptoms. We looked at the operative data to make sure that the two groups were equal. When it comes to OR time, there's no difference between the two groups. We had several parameters that were measured during the procedure, and there's no difference between the two groups. We measured such things as the myotomy length, the esophageal length of the myotomy, the gastric length of the myotomy, and so forth. There was only 2 intraoperative perforations in each group. When we looked at the results, this is what we found when we looked at the symptom frequency pre versus post-op. So now we're looking at the Dor patients who, comparing their preoperatively and postoperatively. What we found was all but 2 of the symptoms had significantly improved in that group. When it comes to symptom severity, we also noticed that all but 2, heartburn and chest pain, had significantly improved in that group. Looking at the Toupet group, as far as symptom frequency, all but heartburn and chest pain had significantly improved in that group. And we looked at the severity and noticed that heartburn and chest pain were the only 2 that did not significantly improve. We then looked at the SF06 for the Dor, pre-op versus post-op, and of the 10 parameters that were measured, 5 of them had significant improvement for this arm of the study. And then we looked at the Toupet group, 7 of the 10 parameters had significant improvement. Then we looked at our 24-hour pH testing, which was done on patients between 6 and 12 months post-operatively. Some patients had a Demeester score. What's presented here is the mean. Some people had a pH of less than 4 for more than 4% of the time. What is important is when we added them all together, this is where we will pause. We looked at the Dor arm. 10 of the 24 patients had abnormal acid reflux, which is 42% of the people in that arm had abnormal acid reflux. Whereas in the Toupet arm, only 4 of the 19 had abnormal acid reflux, which is 21%. However, you'll notice that the p-value did not reach significance. One last thing that we did was we asked, is there any difference between the patients that had normal reflux from abnormal reflux, regardless of the fundoplication that they had? We looked at the symptom scores, and the only thing that fell out as significant was heartburn frequency and severity. There are no significant differences in any of the other 6 symptoms between normal and abnormal pH tests. So in summary, after laparoscopic hilar myotomy, Dor and Toupet fundoplications resulted in comparable degrees of improvement in symptoms. Pathologic acid reflux by 24-hour pH testing was twice as high in the Dor arm than in the Toupet arm, 42 versus 21%, though this did not reach statistical significance. So in conclusion, Dor Toupet equally achieved the primary goal of relief of symptoms and improvement in quality of life. And our results do support the use of pH testing afterwards to identify patients who do have pathologic reflux. This study was supported by SAGE's grant, and we give special thanks to Mary and Kevin who helped us with the database management, and we'd like to thank you for this opportunity.
This paper is open for discussion.
Senator Matar, Indiana. Out of the nearly 30% of patients who did not return back for pH probing, can you tell me what the distribution of them were in terms of Dor versus Toupet?
I'd have to go back and look at the numbers. I don't know them off the top, but we could just subtract out what those numbers were from that first slide.
Jerry Fried, McGill University. I'd like to congratulate the authors on putting together this trial and a lovely presentation. I have a couple of questions. First, I wanted to know how did you decide on the numbers to power the study, and what outcome and what magnitude of difference did you expect? The second question is, how did you manage those people that were excluded? And that is, did you look at whether they represented the whole group in some way, whether their symptom scores, if you were able to get symptom scores and not pH studies, were equivalent with the group that you actually analyzed? My third is a comment just based on our own trial where we've done routine 24-hour pH on our Dor patients, about 120 patients, and found a substantially lower rate of reflux, 11% by pH study, only 5% showing symptoms. And the question really is the way that the Dor is constructed. And I noticed that your Dor is about 3 centimeters long. There are some people that would recommend covering most, if not all, of the exposed mucosa. And that would result in a substantially larger fundoplication and less likelihood of developing a subsequent diverticulum above your wrap. And I wonder if you would comment whether you standardized the way the Dor was done and why you standardized it on that level. Thank you.
Okay. Now on the last question, there was 2 slides I took out because of time. We did standardize the Dor and the Toupet for all the centers. There was not a standardization for the length of the Dor in that protocol, though. So it was up to the physician to decide how long that Dor would be. The first question was about the recruitment. In our original study, the goal was to have 200 people recruited based upon what we thought the difference would be between the 2 groups. Obviously, we did not reach that.
On what outcome, if I might ask?
I'm sorry?
When you calculated your power analysis for your trial, and the numbers were based on expected differences on what primary outcome?
The primary outcome for the expected differences would be symptom. Honestly, I don't know what that particular figure off the top of my head. Dr. Brunt may actually remember that particular number.
I think for a difference of 20%, I think the number was about 120 patients in each arm, which obviously we didn't do. I would say that based on the data that we have currently, to show a significant difference in the rate of acid reflux between the groups, you'd need 75 patients in each group.
Nussbaum, Jacksonville. I enjoyed your paper. I had a question about your definition of pathologic reflux. You stated that there were a higher number of pathologic reflux in the Dor group, yet you said the total Demeester scores in both were at the 7 range, which is not pathologic reflux. I'm trying to understand how you make that conclusion.
So to explain that slide, what was presented was the median value and not the mean because it was a small sample size. The median value was less than 14.72 for the Demeester score. But not everybody had a Demeester score. Some of them had the pH time of less than 4 pH for whatever percentage of time. And so what we did was we looked through the list of patients and saw who had pathologic reflux, meaning a Demeester score above 14.72 or a pH time more than 4% of less than 4 pH. And that's how we got that number at the bottom. So wasn't clear on that slide, but hopefully that cleared up how we got to that number of 10 and 4.
Bill Richards from Mobile. I think this is a very elegant study and congratulate you for presenting it very, very nicely. So I'm going to follow up on Jerry Freed and Mike Nussbaum and everything else. Can you elucidate a little bit more about whether or not this pathologic reflux was supine, i.e. failure for clearance, or upright refluxers, or long-term refluxers, in other words, an abnormally long aspect of reflux where the acid is just staying in the esophagus, related to inadequate clearance? And for that matter, did you do postoperative manometry to assess LES pressure? In other words, does the Toupet cause some sort of obstruction?
To answer the second question, we did post-operative manometry, and they were equivalent. It was a slide that was taken out, but there was significant decrease in both arms, and both them went significantly low. As far as the first question,
What was the average pressure in each group?
The LES basal pressure dropped from about 35 to 40 down to 10 in the Dor group, 13 in the Toupet group, and the residual LES pressure, I think, dropped to around 4 and 5 in each group respectively, so a significant drop in the pressures. In terms of the pH data, there were 4 patients who had Bravo pH in follow-up, so they did not have a Demeester score calculated. So it was in those individuals that we used the percent total time pH less than 4, and if it was over 4%, that was considered an abnormal study. Bill, I don't have the breakdown on supine versus upright reflexes.
Great study.
Sorry, I got those numbers about 3 this morning and didn't get them memorized.
So one of the questions that I have is there can you predict what the impact would be of previous treatment, such as multiple Botoxes, single Botox, balloon dilatation, on what your choice of procedures, and how are those variables managed?
Well, this study would not help answer that question because we didn't have various arms depending on what people had had previous treatments, whether or not they'd had Botox or dilatation. So it would be very difficult to extrapolate from this study to a specific select patient population that you're asking about.
Five patients had Botox pre-op, 15 had dilatations. They weren't pneumatic dilatations, and really no differences in groups, and the number's too small to compare between the two populations.
Thanks, Mike. Thank you very much.
Thank you.